Our next esteemed speaker is Dr. Amrish Agrawal, who is very near and dear to us. Dr. Amrish Agrawal is a senior consultant cardiologist and associate professor of medicine, Fujairah Hospital, UAE. He has more than 25 years experience in Australia, India, and UAE. He's invited faculty and speaker in international meetings such as EuroEco, World Congress across the globe, and ACC and EST meetings, more than 20 publications in peer-reviewed journal, author of several chapters, principal investigator of many international trials. I will hand over the mic to Dr. Rupesh Singh to conduct this session. Dr. Aziz Khan is the co-chairperson. Dr. Rupesh Singh, please initiate the session.
So, good afternoon, everybody. And thanks to Minoria sir for inviting us for as a chairperson for this meeting. So, as we know that the coronary artery disease, the backbone of treatment of these patients are basically dual antiplatelet therapy, particularly those having the acute coronary syndrome or those having revascularization in the form of PCI. But at the same time, this medication also led to the more bleeding chances in this patient. And paradox of these patients are that who are suffering the ischemic risk, they also suffer the bleeding risk more. For example, the aged patient having CKD, they have the chances of more ischemic event. Same time, they have the more chances of having bleeding. So we have to decide somewhere in this path of treatment to de-escalate the therapy for dual antiplatelet of these patients. And I think Dr. Amrish Agrawal doesn't recognize any introduction. Already Minoria sir has given the introduction for him, and he's the best person to discuss this topic. And after this topic, we'll definitely take the question to discuss further this topic. So I'm handing the mic to Dr. Amrish Agrawal.
Let me start by saying, and this quote I read from a prodigy study for some time, and this quote is a very, very hard quote by saying that an interventional practitioner is commonly faced with number of very simple questions. And obviously, these questions are very simple. Even that matter, clinical doctor is also faced with these questions. And the patients wonder why the doctor is not so clear about the answer, because the answer should be obvious to all of us, including the doctors, but in truth are not very commonly known. The reason is that we as a clinician, as like pointed by Dr. Rupesh, is faced with a clinical choice, with a balancing act between the risk of ischemic event and the risk of the bleeding. And this risk is governed by the DAPTs, which we are giving to the patient. DAPT is nothing but dual antiplatelet therapy, because if you give excessive DAPT or if you stop the DAPT prematurely, you subject the patient to ischemic risk, but a prolonged duration of DAPT will expose the patient to the risk of the bleeding, and adverse event of any type, if sufficiently severe, can affect mortality and morbidity. So the European guidelines and American guidelines have been reasonably consistent regarding the duration of DAPT, and they say in no unequivocal terms that if the person has got no high bleeding risk, so the criteria is that the person should not have high bleeding risk, the duration of DAPT recommended is 12 months, and this is class 1 recommendation. The grade may vary A to BR, but this is a class 1 recommendation. The duration can be shortened if somebody has got a high bleeding risk, in which case, in the setting of acute coronary syndrome, you want to shorten to nearly 12 months. But the fact remains that the bleeding is an important point in the equation which you deal with the patient. The reason being is that the risk of the bleeding is very important, and the bleeding subjects the patient to further thrombotic events down the line. And in a study of nearly 12,900 patients with the non-escalation MI, after 30 days, the authors were able to show that the tilting point when the risk of bleeding and the risk of ischemic events is nearly grade 3 bar. And the grade 3 bar is those people who had a drop of nearly 3 to 5 grams of hemoglobin after a bleeding. So once the risk of the bleeding crosses grade 3, the risk of ischemic event is actually outweighed by the risk of bleeding event. So we have to be careful. So minor bleedings we can tolerate, but any substantial bleeding is an issue with the patient. So there's a quicksand which a clinician like us are caught. And this quicksand allows multiple options to be considered in the patient with a DAPT. So can it be shorter? Can we give a shortened DAPT? When we say shortened, we are talking about less than 12 months. But this is not the duration of talk, because we are talking about de-escalation therapy. Can we continue DAPT but they de-escalate the dose. Like for example, make from ticagrelor from 90 milligram to 60 milligram, but continue the same molecule. Continue DAPT, but they de-escalate the drug. That means converting from potent P2Y12 to clopidogrel, or even that matter, even stop aspirin down the line and continue on P2Y12 monotherapy. So the number of studies have looked into these issues, and the reason is that we have a change in the technology and the hardware over number of time. Over these years, our technology for the angioplasty has improved dramatically. The stent technology and the platforms have changed. There's a decreased stent thickness, biocompatible polymers, and there is optimization for the drug release kinetics. Secondly, particularly if the money is not the issue, there is a routine use of imaging such as OCT and FFR for angioplasty. In our hospital, maybe half of the patients have some form of imaging to assess whether the stents are fully expanded and opposed to the arterial wall, which is a function to reduce the complication, to reduce the risk of cardiovascular death and the adverse event. So first question we will address, can we reduce the duration of DAPT? But this question was looked into a meta-analysis, and actually 12 trials have looked into the idea, can we reduce the DAPT? And the majority of these trials were heterogeneous because some included acute coronary syndrome, some included a mix of ACS and the CCS. So if you take only the two trials which looked 100% population of ACS, because today our talk is about ACS, these are the STAMART date and the DAPT attenuation MI. They were widely labeled and open labeled with wide crossover, and many of them used clopidogrel, and they showed divergent result over time. In fact, one trial showed increase in the bleeding complication. So as of now, the guideline of 12 months, they stand for the duration of DAPT unless there is a high risk bleeding. Other options which have been considered over time is to decrease the dose of ticagrelor from nearly 90 milligram to 60 milligram. This is not classical de-escalation. This is the same molecule, only the dose is reduced. But notably, in the Pegasus TIMI trial, this option was considered after 12 months of DAPT. So it doesn't fulfill the title given by Dr. Monoria. It can be de-escalate the DAPT. So one of the trials which looked into de-escalation, we will see down short the line. But the main issues which now we will consider is switching from potent P2Y12 inhibitors such as ticagrelor and prasugrel to clopidogrel. And the second option we'll consider is that short DAPT of 1 to 3 months followed by P2Y12 monotherapy of the same class over the time. So the topic was actually one of the first trial which came out in 2017, which looked at non-guided de-escalation at 30 days post-acute coronary syndrome. So all the patients, they receive potent P2Y12 and they receive for nearly 30 days. And after 30 days, many of these patients were de-escalated down to clopidogrel. And it was the first randomized comparison of DAPT de-escalation in a monocenter center in France, including 646 patients. And the trial was published in 2017. The trial showed very, very clearly there was no difference in the ischemic endpoint with de-escalation. However, the 2 and more than 2 BARC bleeding came down significantly by 70%, and the TIMI major bleeding did not differ between the two groups. So it appears that if you de-escalate from ticagrelor to clopidogrel unguided, at least they show a T+ point with no minus point. Another trial called as TALOS-AMI looked into the secondary of acute myocardial infarction, and this trial was done in Korea, including nearly 30 centers across different place hospitals in Korea, and the majority patients used prasugrel. And in this population of nearly 2,700 patients, so after the index event of acute myocardial infarction of 1 to 12 months, they were actually downgraded to clopidogrel, and this trial was also unguided trial. The trial also shows very significant reduction in the bleeding complications with no change in the ischemic event. So the bleeding complications were reduced by nearly 45%, mainly reduction of 2, 3, and 5 degree of BARC classification of in these patients. And the authors concluded that de-escalation strategy is superior to ticagrelor DAPT in the terms of net clinical benefit. However, we have to remember that this trial was done in Korea, and we know that there is something called a South Asian paradox, and the South Asian paradox, including basically Southeastern paradox, is mainly related to our population, particularly in Japan, Korea, and Philippines, because these people have a very, very high risk of bleeding. So the de-escalation was able to show a much more remarkable benefit. And despite having clopidogrel resistance, the people of this area actually do very well with clopidogrel. So in a meta-analysis which came last year in JACC, which looked at different de-escalation therapy, And in the meta-analysis, authors from Japan, Soci, they were able to conclude that the de-escalation therapy has got a net clinical benefit and has got a statistically significant reduction in the bleeding complications with no change in the ischemic complications. And more notably, the authors in the meta-analysis were able to show that there was actually a reduction in the mortality by de-escalation. So, but again, like we said, the heavy weight of the patients came in the clinical trials and meta-analysis from the South Asian countries, and the South Asian countries are having this benefit with regard to the bleeding by any therapy. There are actually some major issues with the clopidogrel, which all of us in the room are very, very known. The clopidogrel has got a wide variability in the clinical response, and there is a clopidogrel resistance related to the genetic material variability of the patients. So there are some patients which will show clopidogrel resistance, and that is the reason why ticagrelor and the prasugrel in the TB in the Triton trial and other trials were able to show significant advantage over clopidogrel in the net benefit clinical outcomes in the setting of the acute coronary syndrome. So the question comes that if we are able to assess the therapy of clopidogrel, can we make a difference? And one trial look at this concept, and this trial was particularly using the example of platelet function testing. It could serve to make de-escalation safer by identifying low responders to clopidogrel, and somebody low responder, then we will not actually give clopidogrel, we will continue with ticagrelor and the prasugrel. So we'll come back to the tropical ACS syndrome, which showed very clearly this trial was done, look at the guided de-escalation by doing a platelet function testing, and the trial showed that the sum total of the primary endpoint, which included the ischemic endpoint and the bleeding endpoint, was significantly reduced by de-escalation therapy to clopidogrel from the biplatelet guidance. And when we divided the endpoints, they were able to show that the net ischemic benefit point, which include cardiovascular death, myocardial infarction, stent thrombus, and stroke, were no difference by de-escalation versus no de-escalation, but all the benefit came by reduction in the bleeding complications. And like we know from the historical data, the bleeding complications are very, very important. Once you have a bleeding, this predisposes the patient to have further thrombotic event down the line. The conclusion of the author was that the stage adapted and the individualized treatment that included a guided adapt de-escalation provided an effective and safe when compared to uniform potent platelet inhibition in the ACS patient undergoing PCI. And this strategy is feasible and associated with the high treatment adherence. However, these strategies looked at the guided de-escalation, and the guided de-escalation involves the patient to be put on clopidogrel and to check for platelet function test after the patient on clopidogrel. So can we predict by looking at the genetic model? And there were two trials which looked into the genotyping of the patients before they even put on clopidogrel. So you can do actually a genotyping by point of care assay by look and predicting, will this patient respond to clopidogrel and not clopidogrel? And these two trials are trials which are called the popular genetic and the pharmacology trials. And they showed that the genotype guided strategy was not inferior in selecting the patients for de-escalation for the P2 alt inhibitor. So it appears that this concept, which is very important of de-escalation, will come some down the line, and the guidelines will look into it very, very carefully. The de-escalation mainly is going to look after the issue of converting from the potent and expensive molecule to from ticagrelor to Plavix down the line. Another trials which came and looked at the sum total was the analysis which was published and looked at whether can we give a short DAP followed by P2-L2 inhibitor monotherapy. And actually 5 trials looked into this example. And this is the article from the European Heart Journal, which looked at these 5 articles. Among them, the top trial, which is the Global Leaders trial, was actually neutral, but there are a lot of criticism of Global Leaders trial, how it was conducted. And the more importantly, they used ticagrelor only for 1 month before de-escalated. But the 2 relevant trials are the TICO trial and the TWILIGHT trial. So the TWILIGHT trial was conducted by Roxana Mehran from New York, and she looked into the patients who had a high risk of ischemic event and the high risk of bleeding. So these patients were actually randomized to ticagrelor versus aspirin of the standard 12 months versus ticagrelor and placebo. So after nearly 3 months of doing DAP therapy with ticagrelor and aspirin, they were actually randomized into just aspirin with the ticagrelor alone and the DAP combination for 12 months. And after 12 months, they were observed for nearly 3 months treatment. And what the result was able to show the results were able to show in the down that the same benefits, there were no change in the ischemic endpoint over the time, and there was a significant reduction in the bleeding complications by nearly 45% in the arm, which is receive only ticagrelor without Plavix. The same data came out from the TICO trial. The TICO trial was looking again in the center of Korea, where the 38 centers and the acute coronary syndrome patients who had a very, very specific type of sirolimus eluting stent using a Osirio platform. And these authors, they looked at the sum total of benefits. So they looked at the net adverse clinical event of ticagrelor monotherapy after 3 months of DAPT therapy. So it appears the global leaders trial used 1 month of DAPT therapy, which was inferior, but the 3 months of DAPT therapy will be needed. And when I was speaking to some authors which are looking in the studies, they said the ischemic event actually stabilizes by 3 months. And in the result, the authors were able to show very clearly that the net adverse clinical event was reduced in the total arms which received only the ticagrelor monotherapy after 3 months of DAPT, and this was driven mainly by the major risk of bleeding in this population. So when we look at all these 5 trials which included DAPT with the de-escalation to ticagrelor monotherapy, which includes the global leader trials, nearly 50% of the population, Smart Choice, Stop DAPT, TWILIGHT, and TICO, total population including 32,000 patients. And in this meta-analysis which came in circulation, the authors were able to show that the decrease in the major bleeding by nearly 40%, decrease in the MACE by 12%, and the neutral on the stent thrombosis. However, despite of all this data, the European Society in the latest guidelines of 2020, they say that the de-escalation of P2Y12 inhibitor therapy may be considered for acute coronary syndrome deemed unsuitable for the potent platelet inhibition. The de-escalation may be done unguided based on the clinical judgment or guided by the platelet function testing or CY2, C19 genotyping, depending on the patient risk profile, availability of the respective assays. But for the second one, the class recommendation is to be level of evidence A. So ladies and gentlemen, I come to the end of the talk by saying certain things that we have to not use one approach for all patients. We have to individualize. And how do we individualize? As Dr. Rupesh said, we have to assess the bleeding risk and we have to assess the ischemic risk. If somebody is on a high ischemic risk with a low bleeding risk, there is no question, prolonged DAPT therapy. And when we say prolonged, we are talking about 12 months. Extension can be 30 months, as seen by the DAPT trial, can be seen in the Pegasus trial to a lower dose of ticagrelor for a more longer time. If somebody has got a low ischemic risk and the high bleeding risk, in such case, there is also no confusion. All of us in the room will look at probably 6 months of DAPT therapy in this population. However, if other group of populations, which we have normal bleeding risk and normal ischemic risk, or high bleeding risk and high ischemic risk is there when the confusion starts, and we go back to the first slide in which we also not sure about the data, we can actually consider the option of switching for potent P2Y12 inhibitors such as ticagrelor and prasugrel to clopidogrel, and can be guided, unguided. In our hospital, we use Verify Now assay for platelet reactivity for any patients which we think about starting clopidogrel, or we think that he cannot afford ticagrelor down the line. We will do this assay before discharge. And in some people, we can think, as the trial showed very, very positive data from a TWILIGHT and TICO trial, that give them short DAPT and reduce ticagrelor monotherapy. And this is a tailored approach because we know that aspirin by itself is nearly causing huge amount of bleeding in the population. And the risk of the benefit of potent P2Y12, such as ticagrelor, can actually abort the risk of aspirin combination therapy. With this, I come to the end of the talk. And thank you very much. And sorry for the technical glitches which occur in this population.
Thank you, Dr. Agrawal.
Okay, so thanks, Dr. Amrish, for the nice presentation and concluding. And as we know that in certain scenarios, the questions are very clear. Like the example, if patient have normal bleed and normal ischemic events, so we have to give 12 months. But the problem arises when patient have particularly high ischemic risk and high bleeding risk, particularly old, frail patient having a lot of comorbidities. As you have told, minimum therapy should be DAPT in these patients minimum 3 months. And TWILIGHT and TICO trial has shown that we can switch over to them monotherapy, barring the aspirin. But this monotherapy should be at least potent one like ticagrelor and other prasugrel, these molecules. So I think now floor is open for any question from the audience or any other questions.
Amrish, your thoughts on prasugrel de-escalating to 5 milligram. Many people
Yes.
yeah.
I can give only theoretical opinion of it because in UAE we don't have prasugrel. In our most of the colleagues of mine, we are using exclusively ticagrelor and aspirin. Now prasugrel is very popular in East Asia, and they have a special preparation, only 5 milligram and even lower dose available for their population. So these people are being found have a special type situation which I'm describing in the literature. They are very, very sensitive to antiplatelet agents, so they don't so much ischemic event. They are prone to bleeding. So for them, their authors and those country people, at least in Korea and Japan, they are interested in reducing the risk of bleeding. And they don't show, despite of having clopidogrel resistance seen by verified analysis or genetic, they actually don't show in the practical wise that this laboratory genetic resistance is having an effect in the population. So this prasugrel, we don't have much experience. So this all theoretical experience we can talk about.
Because you have been using 5 milligram de-escalating after some time.
Yes.
I think many cardiologists are using. And it has been given in some trials also, they have mentioned that de-escalating to 5 milligram use equal results. Yeah.
But all these trials have come from East Asia. This is the thing.
Patient with multiple angioplasty and diabetic, I think these patients better to continue for.
So there are certain clinical criteria and certain procedure criteria you can use to decide about prolonged depth therapy, particularly if you have a patient with multivessel PCI, particularly the stent length is long, particularly if you have small vessels, particularly you are using left main angioplasty and a trifurcation lesion. These are patients you don't want to take the risk of stopping depth prematurely. So perhaps a longer depth is more better option suitable in these patients.
Any question from
Dr. Khan, can I come in for a question?
Yes, sir.
Yeah, just Dr. Amrish, thank you very much. Especially the last slide was very enlightening. That summarizes the whole concept, how to go about. I wanted to extend on the question what Dr. Khan asked, that what is the long term? So I think we should not forget the COMPASS trial. And there are certain patients, like you said, multivessel disease with diabetes. These are the patients who can be taken on rivaroxaban 2.5 milligram twice a day with single antiplatelet. So there is a score, as I mentioned in the morning chats, to PARC score. That includes peripheral arterial disease. That includes age more than 75 years. That includes renal dysfunction. And C is multivessel disease. If you score these patients and your patient score is more than 4 years, after 1 year I'm not talking of first year post PCI. If your score is high, more than 4, then these patients are better off with COMPASS approach rather than DAPT approach, because DAPT approach does not give mortality reduction. Thank you.
Thank you, Dr. Rajiv. Actually, I didn't touch the extension of...
I agree. I agree.
Yeah.
I just put across COMPASS.
No, that's very much a point. In our hospital, we have set of patients which have got coronary angioplasty, peripheral angioplasty, and they have a stroke also. So in that patient, vascular protection takes precedence over once they cross the period, and some of these patients are actually rivaroxaban 2.5 milligram BID.
I agree. And the only limited point is never, ever forget and underestimate peripheral arterial disease.
Yes.
That's a very big denominator for future ischemic events. Thank you, Dr. Amrish. Thank you very much.
With this, we conclude this session.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.